Question 1. A 68-year-old male presents with sudden onset of severe, tearing back pain radiating to his abdomen, accompanied by weakness in both legs. His skin is pale and diaphoretic, and peripheral pulses are difficult to palpate. Blood pressure is 88/50 mmHg, heart rate 118 bpm, respirations 22 bpm. ECG shows sinus tachycardia. What is the most critical immediate intervention after ensuring airway and breathing are patent? A. Administer 324 mg aspirin chewable. B. Initiate rapid fluid resuscitation with 500 ml 4 crystalloid boluses. C. Prepare for immediate cardioversion due to tachycardia. D. Apply a tourniquet above the groin to control potential internal hemorrhage. Answer: B. Initiate rapid fluid resuscitation with 500 ml 4 crystalloid boluses. This question tests your ability to recognize and manage a potentially life-threatening vascular emergency, specifically a ruptured abdominal aortic aneurysm, AAA. The keywords: sudden onset, severe tearing back pain radiating to abdomen, weakness in both legs, pale, diaphoretic skin, hypotension, and tachycardia are classic signs of a ruptured AAA with hypovolemic shock. The most critical immediate intervention after securing the airway and breathing is to address the severe hypovolemia caused by internal bleeding by initiating rapid fluid resuscitation, typically with crystalloids in boluses, to support blood pressure and perfusion until definitive surgical care can be achieved. Administering aspirin is for cardiac ischemia, cardioversion is for unstable tachyarrhythmias, and a tourniquet is for external compressible hemorrhage, none of which are appropriate here. Remember, in suspected ruptured AAA with shock, aggressive fluid resuscitation is key to maintaining vital organ perfusion while transporting rapidly to a facility capable of emergency surgery. Question 2. You are called to a 2-year-old child who ingested an unknown quantity of caustic drain cleaner approximately 15 minutes ago. The child is crying, drooling excessively, and resisting attempts to open her mouth. Her parents report seeing burns around her lips. What is the most appropriate initial management strategy? A. Administer activated charcoal orally to absorb the caustic substance. B. Induce vomiting to remove the substance from the stomach. C. Administer oral milk or water to dilute the substance. D. Maintain airway patency and rapid transport to a specialized facility. Answer: D. Maintain airway patency and rapid transport to a specialized facility. This question focuses on the emergency management of caustic ingestion in a pediatric patient, emphasizing the critical importance of airway protection. The keywords caustic drain cleaner, drooling, resisting attempts to open mouth, and burns around lips all point to severe upper airway swelling and potential obstruction. Administering activated charcoal, inducing vomiting, or diluting with oral fluids are contraindicated or not the priority in caustic ingestions because they can worsen airway swelling, cause further injury, or induce aspiration. The immediate priority is always airway management, followed by rapid transport to a facility equipped for advanced airway management and endoscopic evaluation. Remember, in caustic ingestions, the primary concern is airway compromise and preventing further damage, so focus on supportive care and rapid transport. Question 3. A 45-year-old male with a history of type 2 diabetes presents with altered mental status. His skin is warm and dry, he is tachycardic at 110 bpm, hypotensive at 80/50 millimeter of mercury, and his respirations are rapid and deep, Kussmaul breathing, at 30 bpm. His blood glucose level is 680 mg per deciliter. What is the most appropriate immediate pre-hospital treatment? A. Administer a 25-gram dextrose bolus 4. B. Administer 0.4 mg naloxone 4/IM. C. Administer 1 liter normal saline 4 bolus over 10 minutes. D. Administer 2 mg midazolam 4 for potential seizures. Answer: C. Administer 1 liter normal saline 4 bolus over 10 minutes. This question assesses your understanding of diabetic ketoacidosis, DKA, a severe complication of diabetes. The key clues are altered mental status, warm and dry skin, tachycardic, hypotensive, rapid and deep respirations, Kussmaul breathing, and a blood glucose level of 680 mg per deciliter. These findings are classic for DKA, which involves severe dehydration due to osmotic diuresis. While the blood glucose is high, administering dextrose would worsen the hyperglycemia. The primary immediate pre-hospital treatment for DKA with hypotension and dehydration is aggressive fluid resuscitation with normal saline to restore circulating volume and improve perfusion. For instance, giving a fluid bolus helps correct the severe dehydration and shock caused by the high blood glucose pulling water out of the cells. Remember that DKA patients are critically dehydrated, and fluid replacement is the cornerstone of initial treatment, not simply lowering blood glucose. Question 4. You are managing an unresponsive 72-year-old female patient with a known history of severe COPD. Her SpO2 is 82% on room air, and she has shallow, labored breathing at 8 breaths per minute. Her end-tidal CO2, EtCO2, is 85 mm of mercury. What is the most appropriate initial ventilation strategy? A. Administer oxygen via nasal cannula at 2 lpm. B. Apply a non-rebreather mask at 15 lpm. C. Assist ventilations with a bag valve mask, BVM, and supplemental oxygen. D. Place her in the recovery position and monitor her breathing. Answer: C. Assist ventilations with a bag valve mask, BVM, and supplemental oxygen. This question tests your ability to prioritize airway and ventilation in a patient with respiratory failure, particularly in the context of COPD. The critical clues are unresponsive, shallow, labored breathing at 8 breaths per minute, SpO2 82%, and an extremely high EtCO2 of 85 mm of mercury, indicating severe hypoventilation and carbon dioxide retention. While COPD patients can have a hypoxic drive, severe hypoventilation, low respiratory rate and high EtCO2 indicates acute respiratory failure requiring immediate ventilatory support, not just supplemental oxygen or repositioning. Assisting ventilations with a BVM and supplemental oxygen will effectively improve oxygenation and remove excess CO2, regardless of her COPD history, because her ventilation is inadequate. Always prioritize adequate ventilation and oxygenation in respiratory failure, even if it means providing assisted breaths, as life-threatening hypoxemia and hypercapnia are imminent. Question 5. A 35-year-old male presents with acute onset, severe testicular pain radiating to his lower abdomen, accompanied by nausea and vomiting. On examination, the affected testicle appears swollen, elevated, and exquisitely tender to touch. What is the most critical pre-hospital management priority beyond pain control? A. Rapid transport to an appropriate medical facility. B. Application of ice packs to the scrotum. C. Attempt manual detorsion of the testicle. D. Administer prophylactic antibiotics. Answer: A. Rapid transport to an appropriate medical facility. This question assesses your recognition of a time-sensitive urological emergency, testicular torsion. The keywords acute onset, severe testicular pain radiating to abdomen, nausea and vomiting, swollen, elevated, exquisitely tender testicle are classic signs of testicular torsion. Testicular torsion is a surgical emergency where the blood supply to the testicle is compromised, and irreversible damage can occur within hours. While pain control is important, the most critical pre-hospital priority is rapid transport to a facility where surgical detorsion can be performed quickly to preserve the testicle. Attempting manual detorsion pre-hospital is typically outside the scope of most EMT/paramedic protocols, and antibiotics are for infection, not torsion. Remember, any sudden, severe testicular pain, especially with associated symptoms, should prompt immediate suspicion of torsion and necessitate urgent transport. Question 6. You are called to a 6-month-old infant with a 2-day history of poor feeding, irritability, and intermittent, sudden episodes of inconsolable crying where the infant draws their legs up to their chest. The parents report recent current jelly stools. What is the most likely underlying condition? A. Appendicitis. B. Gastroenteritis. C. Pyloric stenosis. D. Intussusception. Answer: D. Intussusception. This question describes a classic presentation of intussusception, a serious condition in infants where one part of the intestine telescopes into another. The key clues are 6-month-old infant, common age for this, intermittent, sudden episodes of inconsolable crying where the infant draws their legs up to their chest, painful spasms, and most critically, current jelly stools, stools mixed with blood and mucus. Appendicitis is less common in this age group and presents differently. Gastroenteritis typically involves watery diarrhea, and pyloric stenosis causes projectile vomiting. Recognizing this constellation of symptoms, especially the characteristic stools and intermittent abdominal pain, is crucial because intussusception can lead to bowel obstruction and ischemia, requiring urgent medical attention. For instance, the infant's leg drawing suggests severe colicky pain, indicating an acute abdominal process. Question 7. A 28-year-old pregnant patient, 36 weeks gestation, presents with sudden onset of painless, bright red vaginal bleeding. Her vital signs are stable, and the fetus has a strong heart rate. She denies abdominal pain or contractions. What is the most likely cause of her bleeding? A. Ectopic pregnancy. B. Abruptio placentae. C. Placenta previa. D. Spontaneous abortion. Answer: C. Placenta previa. This question tests your knowledge of common causes of third trimester vaginal bleeding. The key elements are 36 weeks gestation, sudden onset, painless, bright red vaginal bleeding, and stable vital signs with no abdominal pain or contractions. This presentation is highly characteristic of placenta previa, where the placenta covers the cervix. Abruptio placentae typically presents with painful bleeding, uterine tenderness, and often signs of fetal distress. Ectopic pregnancy occurs much earlier in pregnancy, and spontaneous abortion, miscarriage, usually occurs before 20 weeks. Recognizing that painless bright red bleeding late in pregnancy often points to placenta previa is crucial for appropriate management and transport to a facility with obstetric capabilities. For example, knowing this helps you avoid internal vaginal exams, which can worsen bleeding in placenta previa. Question 8. You are managing a patient with suspected opioid overdose who is unconscious, has shallow respirations at 6 breaths per minute, and pinpoint pupils. After ensuring an open airway, what is the most appropriate next step? A. Administer 2 mg naloxone intranasally, IN. B. Initiate positive pressure ventilation with a bag valve mask, BVM. C. Place the patient in the recovery position. D. Obtain a 12-lead ECG. Answer: B. Initiate positive pressure ventilation with a bag valve mask, BVM. This question emphasizes the immediate life-saving priority in severe respiratory depression from opioid overdose. While naloxone is indicated, the keyword shallow respirations at 6 breaths per minute indicates critical respiratory depression, bordering on respiratory arrest. In such a scenario, the most immediate and critical intervention is to support ventilation with a bag valve mask, BVM, to improve oxygenation and remove carbon dioxide before or concurrent with naloxone administration. Naloxone takes time to work, and the patient needs oxygen now. For instance, if you wait for naloxone to take effect without ventilatory support, the patient's oxygen saturation will drop dangerously low. Always remember to prioritize the ABCs: airway, breathing, circulation. In severe respiratory depression, breathing support comes first. Question 9. During a mass casualty incident, MCI, you encounter a patient who is unconscious, has no spontaneous respirations, and a radial pulse is absent. After repositioning the airway, there is still no spontaneous breathing. What start triage category should this patient be assigned? A. Immediate, red. B. Delayed, yellow. C. Minor, green. D. Deceased, black. Answer: D. Deceased, black. This question tests your understanding of the START, simple triage and rapid treatment, triage system, specifically the criteria for declaring a patient deceased. The keywords are unconscious, no spontaneous respirations, and radial pulse absent. According to START, if a patient is not breathing after an airway reposition, indicating apnea, not just obstruction, and has no pulse, they are categorized as deceased or expectant, black tag. This is because in an MCI, resources are limited, and such patients are unlikely to survive without extensive, immediate intervention that would divert resources from savable patients. For example, if you spend time trying to resuscitate this person, you might miss helping 3 other people who are immediate and could be saved. Remember, the START system is designed for rapid assessment and resource allocation in chaotic environments, prioritizing those with the best chance of survival. Question 10. A 55-year-old male is found unconscious in his garage with the car engine running. His skin is cherry red and he has bilateral headaches. His SpO2 is 100% on pulse oximetry. What is the most likely underlying cause of his condition? A. Cyanide poisoning. B. Opioid overdose. C. Carbon monoxide poisoning. D. Acute stroke. Answer: C. Carbon monoxide poisoning. This question assesses your ability to identify carbon monoxide, CO, poisoning, a dangerous condition often presenting with misleading vital signs. The key clues are unconscious, car engine running in garage, cherry red skin, and bilateral headaches. The SpO2 of 100% on pulse oximetry is a critical distractor. Standard pulse oximeters cannot differentiate between oxyhemoglobin and carboxyhemoglobin, CO bound to hemoglobin, leading to falsely normal or high readings. Carbon monoxide displaces oxygen from hemoglobin, causing cellular hypoxia despite adequate oxygen saturation readings. Cyanide poisoning typically doesn't cause cherry red skin. Opioid overdose causes respiratory depression and pinpoint pupils, and stroke presents differently. The most appropriate pre-hospital intervention involves immediate removal from the toxic environment and administration of 100% high-flow oxygen. For instance, the cherry red skin is due to CO binding to hemoglobin, giving the blood a brighter red color, which is a classic, though not always present, sign. Question 11. You are treating a 3-year-old child who fell from a second-story window. The child is unconscious, breathing shallowly, and has a large hematoma over the left parietal region. Pupils are unequal, with the left pupil dilated and sluggishly reactive. What is the most critical immediate intervention to address presumed increased intracranial pressure? A. Administer hypertonic saline intravenously. B. Perform hyperventilation to a target EtCO2 of 25 mm of mercury. C. Maintain normal body temperature and elevate the head of the stretcher to 30 degrees. D. Administer a rapid intravenous fluid bolus to increase cerebral perfusion. Answer: C. Maintain normal body temperature and elevate the head of the stretcher to 30 degrees. This question focuses on the acute management of suspected increased intracranial pressure, ICP, in a pediatric trauma patient. The keywords fall from second-story window, unconscious, large hematoma over left parietal region, and unequal pupils, left dilated and sluggish are all signs of severe head trauma with possible herniation. While hypertonic saline can be used, and controlled hyperventilation might be considered in dire herniation, but typically avoided otherwise due to risk of cerebral ischemia, the most immediate and universally applicable pre-hospital interventions are maintaining normal body temperature, avoiding hyperthermia which increases metabolic demand, and elevating the head of the stretcher to 30 degrees to promote venous drainage from the brain, thereby helping to reduce ICP without compromising cerebral perfusion. Administering a rapid fluid bolus can worsen cerebral edema if not carefully titrated. The goal is to optimize cerebral perfusion pressure while carefully managing ICP. Question 12. A 70-year-old male with a history of heart failure reports sudden onset of shortness of breath that woke him from sleep. He is sitting upright, using accessory muscles to breathe, and has frothy pink sputum. His SpO2 is 85% on room air, and crackles are auscultated bilaterally halfway up the lung fields. What is the most appropriate initial pharmacological intervention, if available and not contraindicated? A. Administer 0.4 mg sublingual nitroglycerin every 5 minutes. B. Administer 2.5 mg albuterol via nebulizer. C. Administer 2 mg intravenous furosemide. D. Administer 250 ml normal saline bolus. Answer: A. Administer 0.4 mg sublingual nitroglycerin every 5 minutes. This question tests your management of acute decompensated heart failure with pulmonary edema. The critical clues are sudden onset shortness of breath that woke him from sleep, paroxysmal nocturnal dyspnea, frothy pink sputum, crackles bilaterally, and a history of heart failure. This presentation is characteristic of acute pulmonary edema due to left-sided heart failure. While loop diuretics like furosemide are definitive hospital treatments, in the pre-hospital setting, nitroglycerin is often the first-line pharmacological agent. Nitroglycerin is a potent vasodilator that reduces preload and afterload, decreasing the workload on the heart and helping to shift fluid from the lungs, improving breathing. Albuterol is for bronchospasm, and a fluid bolus would worsen the pulmonary edema. For instance, nitroglycerin helps your body dry out the lungs by making it easier for the heart to pump and reducing pressure in the blood vessels around the lungs. Question 13. You respond to a 40-year-old female complaining of a severe thunderclap headache, described as the worst headache of her life, with sudden onset during exertion. She is alert and oriented, but states she feels nauseous and has a stiff neck. Her vital signs are stable. What is your primary concern and management priority? A. Migraine headache, administer analgesics. B. Subarachnoid hemorrhage, rapid transport to a stroke center. C. Tension headache, advise rest and over-the-counter pain relievers. D. Meningitis, prepare for droplet precautions and consider antibiotics. Answer: B. Subarachnoid hemorrhage, rapid transport to a stroke center. This question assesses your ability to recognize a potentially life-threatening neurological emergency. The keywords severe thunderclap headache, described as the worst headache of her life, with sudden onset during exertion, are classic red flags for a subarachnoid hemorrhage, SAH. While symptoms like nausea and stiff neck can overlap with other conditions, the specific description of the headache strongly points to SAH, which is often caused by a ruptured aneurysm. Meningitis would typically have fever and a more gradual onset, and migraines or tension headaches usually don't present with such sudden, extreme pain. The primary concern is brain bleed, and the management priority is immediate rapid transport to a facility capable of advanced neurological imaging and intervention. For example, if you hear "worst headache of my life," especially if it came on instantly, think serious brain problem and get them to the hospital fast. Question 14. A 60-year-old male presents with sudden onset of unilateral facial droop, slurred speech, and weakness in his right arm and leg. His symptoms began 30 minutes ago. Your assessment reveals a blood glucose of 110 milligrams per deciliter. What is the most critical intervention to prepare for during transport? A. Administer aspirin 324 milligrams chewable. B. Obtain a 12-lead ECG. C. Determine the exact time of symptom onset, last known well. D. Administer supplemental oxygen via nasal cannula. Answer: C. Determine the exact time of symptom onset, last known well. This question focuses on acute stroke management and the critical importance of the last known well time. The keywords sudden onset, unilateral facial droop, slurred speech, and weakness in right arm and leg are classic signs of an acute ischemic stroke. While aspirin, oxygen, and an ECG are part of comprehensive stroke care, the single most critical piece of information for hospital treatment decisions, specifically thrombolytic therapy like TPA, is the precise time the symptoms began or when the patient was last known to be symptom-free. This last known well time dictates the window of opportunity for potentially life-saving interventions. For instance, if a patient can receive TPA within a certain time frame, their chances of recovery dramatically improve, and you must know that time. Question 15. You are managing a 24-year-old male who was found unresponsive after a suspected opiate overdose. He is apneic and pulseless. After initiating CPR and requesting advanced backup, what is your next most appropriate action? A. Administer 2 mg naloxone 4. B. Attach automated external defibrillator, AED, pads and analyze rhythm. C. Attempt advanced airway placement immediately. D. Administer dextrose 50% 4. Answer: B. Attach automated external defibrillator, AED, pads and analyze rhythm. This question assesses your immediate priorities in cardiac arrest, even when an overdose is suspected. The keywords apneic and pulseless indicate cardiac arrest, regardless of the underlying cause. While naloxone is appropriate for an opiate overdose, it is secondary to standard cardiac arrest management in an apneic, pulseless patient. The most appropriate next action after initiating CPR is to attach AED pads and analyze the rhythm to determine if a shockable rhythm, VF/VT, is present, as early defibrillation significantly improves survival rates for these rhythms. Advanced airway placement or dextrose are not initial priorities in cardiac arrest. Always remember, when a patient is pulseless, the immediate priority is CPR and defibrillation as per the cardiac arrest algorithm, then addressing potential underlying causes. Question 16. A 16-year-old male presents with severe pain and swelling to his right ankle after rolling it during a basketball game. On examination, there is marked deformity, and he is unable to bear weight. Distal pulses are strong, and sensation is intact. What is the most appropriate pre-hospital intervention? A. Apply an elastic bandage and advise him to keep weight off it. B. Attempt to manually reduce the deformity back into anatomical alignment. C. Immobilize the ankle in a padded splint in the position of comfort. D. Administer a large dose of pain medication and rapid transport. Answer: C. Immobilize the ankle in a padded splint in the position of comfort. This question focuses on the appropriate management of suspected extremity fractures with deformity. The keywords are severe pain and swelling, marked deformity, and unable to bear weight, all pointing to a significant fracture or dislocation. While pulses and sensation are intact, attempting to reduce a deformed extremity pre-hospital without specific medical direction is generally not within the scope of basic or intermediate providers unless there is clear neurovascular compromise. The most appropriate action is to immobilize the injured extremity in the position of comfort, using a padded splint, to prevent further injury and reduce pain, followed by transport. For example, splinting it as it lies helps prevent sharp bone ends from damaging nerves or blood vessels during movement. Pain management and transport are important, but splinting is the immediate mechanical intervention. Question 17. You are assessing a patient in respiratory distress. Your ETCO2 reading shows a shark fin waveform. What does this waveform pattern most likely indicate? A. Esophageal intubation. B. Air trapping/bronchospasm. C. Cardiac arrest with inadequate compressions. D. Hyperventilation with hypocarbia. Answer: B. Air trapping/bronchospasm. This question tests your interpretation of capnography waveforms, a critical skill in advanced airway management and respiratory assessment. A shark fin waveform, which shows a gradual upslope during exhalation rather than a sharp rise, is classic for conditions that cause airflow obstruction, such as bronchospasm, example asthma, COPD exacerbation, or air trapping. The gradual rise indicates that exhalation is prolonged and difficult. Esophageal intubation would result in a flat line or very low, inconsistent CO2 readings. Inadequate compressions in cardiac arrest cause a low, fluctuating CO2, and hyperventilation causes overall low ETCO2, but not this specific shape. Understanding waveform morphology provides crucial real-time insight into the patient's ventilatory status. For instance, if you see this shape in a patient with wheezing, it confirms air movement issues. Question 18. A 65-year-old female presents with sudden onset of severe, crushing chest pain radiating to her left arm. She is pale, diaphoretic, and extremely anxious. Her blood pressure is 148/92 mmHg, heart rate 98 bpm, respirations 20 bpm. Aspirin has been administered. What is the most appropriate next step for pain and cardiac workload reduction, assuming no contraindications? A. Administer intravenous morphine sulfate. B. Administer nitroglycerin 0.4 mg sublingually. C. Prepare for immediate synchronized cardioversion. D. Administer 2 mg intravenous adenosine. Answer: B. Administer nitroglycerin 0.4 mg sublingually. This question assesses your management of acute coronary syndrome, ACS, specifically myocardial infarction. The keywords sudden onset, severe, crushing chest pain radiating to left arm, pale, diaphoretic, and anxious are classic signs. After administering aspirin, which inhibits platelet aggregation, the next most appropriate pre-hospital intervention for ischemic chest pain, assuming no contraindications, like hypotension or recent PDE5 inhibitor use, is nitroglycerin. Nitroglycerin causes vasodilation, reducing preload and afterload, which decreases myocardial oxygen demand and can improve blood flow to the ischemic heart muscle, thus reducing pain. Morphine is an alternative for pain if nitroglycerin is ineffective or contraindicated. Synchronized cardioversion is for unstable tachyarrhythmias, and adenosine is for supraventricular tachycardia. Remembering the standard MONA-B, morphine, oxygen, nitroglycerin, aspirin, beta blockers, sequence, with nitroglycerin being a key component after aspirin, is helpful. Question 19. You are evaluating a patient with a severe anaphylactic reaction. They are hypotensive, BP 70/40 mmHg, wheezing, and have widespread urticaria. After ensuring airway patency, what is the most critical immediate intervention? A. Administer diphenhydramine 4. B. Administer nebulized albuterol. C. Administer epinephrine 0.3 mg IM. D. Initiate a rapid 4-fluid bolus of normal saline. Answer: C. Administer epinephrine 0.3 mg IM. This question tests your priority management in severe anaphylaxis. The keywords severe anaphylactic reaction, hypotensive, wheezing, and widespread urticaria indicate a life-threatening, multi-system allergic response. While fluid boluses, antihistamines, diphenhydramine, and bronchodilators, albuterol, are adjunctive therapies, epinephrine is the cornerstone of treatment for severe anaphylaxis. It is a vasoconstrictor and bronchodilator that rapidly reverses the life-threatening symptoms of hypotension and bronchospasm by constricting blood vessels and relaxing airway smooth muscles. Administering it intramuscularly is typically the fastest and safest route pre-hospital for initial doses. For example, if you see widespread hives, wheezing, and low blood pressure, think epinephrine first because it's the only drug that can reverse all those critical signs. Question 20. A 78-year-old male nursing home resident is found unresponsive. Staff report he has a history of dementia and was recently treated for pneumonia. His temperature is 94.0 degrees Fahrenheit 34.4 degrees Celsius, heart rate 120 bpm, blood pressure 80/50 mm of mercury, respirations 24 bpm. His skin is cool and clammy. What is the most likely underlying condition causing his presentation? A. Hypothermia. B. Cardiogenic shock. C. Septic shock. D. Hypoglycemia. Answer: C. Septic shock. This question challenges you to identify septic shock, particularly in an elderly patient who may not present with classic signs. The keywords 78-year-old nursing home resident, history of dementia, recently treated for pneumonia, unresponsive, temperature 94.0 degrees Fahrenheit 34.4 degrees Celsius, tachycardia, and hypotension are highly suggestive of sepsis progressing to septic shock. While low temperature, hypothermia, is present, it's often a sign of overwhelming infection in the elderly, who may not mount a fever. The combination of infection history, pneumonia, altered mental status, and signs of shock, hypotension, tachycardia, cool/clammy skin, points strongly to sepsis. Cardiogenic shock would typically have lung congestion, and hypoglycemia would be ruled out by a blood glucose test. Recognizing that an elderly patient with infection can become hypothermic and hypotensive due to sepsis is crucial for early intervention. Question 21. You arrive on scene of a single-vehicle collision. The conscious driver, 30 years old, has a significant abrasion to her forehead and complains of neck pain. She denies loss of consciousness. Your primary assessment is otherwise unremarkable. What is the most appropriate next step in managing her cervical spine? A. Perform a rapid extrication onto a long backboard. B. Apply a cervical collar and manually stabilize her head. C. Assess range of motion in her neck to rule out injury. D. Allow her to self-extricate if she can do so without pain. Answer: B. Apply a cervical collar and manually stabilize her head. This question assesses proper cervical spine immobilization techniques in a trauma patient. The keywords single vehicle collision, complains of neck pain, and significant abrasion to her forehead indicate a potential mechanism for cervical spine injury, even if she denies loss of consciousness. The most appropriate immediate action is to apply a cervical collar and maintain manual stabilization of the head and neck to prevent further injury until the spine can be fully assessed or cleared by medical professionals. Performing a rapid extrication is only for immediate life threats. Assessing range of motion could worsen an existing injury, and allowing self-extrication is contraindicated with neck pain after trauma. Always assume a cervical spine injury in trauma patients with neck pain or significant mechanisms until proven otherwise, and prioritize immobilization. Question 22. A 6-year-old child presents with sudden onset of inspiratory stridor, drooling, and a muffled voice. He is sitting in a sniffing position and is reluctant to lie down. His parents state he developed these symptoms rapidly after dinner. What is the most likely cause of his distress? A. Croup. B. Epiglottitis. C. Asthma exacerbation. D. Foreign body airway obstruction. Answer: D. Foreign body airway obstruction. This question tests your ability to differentiate causes of acute upper airway obstruction in children. The critical clues are 6-year-old child, sudden onset, inspiratory stridor, drooling, muffled voice, sniffing position, and symptoms appearing rapidly after dinner. While epiglottitis, which is rare due to vaccinations, can cause similar symptoms, the sudden onset and association with after dinner strongly point to a foreign body airway obstruction, FBAO, such as a piece of food. Croup typically has a barking cough and slower onset, and asthma exacerbation causes expiratory wheezing. The sniffing position is an attempt to optimize airway opening, common in both FBAO and epiglottitis, but the acute, food-related onset points to obstruction. The priority is to attempt to remove the obstruction if visible or transport immediately. Question 23. You are assessing a patient found unresponsive in an industrial setting. Your partner notes a strong odor of almonds emanating from the patient. The patient has pink skin, rapid breathing, and a weak pulse. What specific type of poisoning should you immediately suspect? A. Hydrogen sulfide poisoning. B. Organophosphate poisoning. C. Carbon monoxide poisoning. D. Cyanide poisoning. Answer: D. Cyanide poisoning. This question challenges you to recognize a specific and highly lethal poisoning. The keywords unresponsive in an industrial setting, a strong odor of almonds, though not everyone can smell it, pink skin, rapid breathing, and a weak pulse are classic indicators of cyanide poisoning. Cyanide interferes with cellular respiration, leading to profound metabolic acidosis and cellular hypoxia. Hydrogen sulfide smells like rotten eggs. Organophosphates cause sludgem symptoms, salivation, lacrimation, urination, defecation, GI upset, emesis, meiosis, and carbon monoxide causes cherry red skin with a normal pulse oximetry. The odor of almonds is a classic, though unreliable, clue for cyanide. For instance, cyanide causes cellular asphyxia, making the body unable to use oxygen, leading to rapid deterioration. Question 24. A 40-year-old male presents with sudden, sharp, tearing chest pain radiating to his back between the shoulder blades. He is pale and diaphoretic. His blood pressure is 180/100 mmHg in the right arm and 130/80 mmHg in the left arm. What is the most critical suspected condition? A. Myocardial infarction. B. Pericarditis. C. Aortic dissection. D. Pulmonary embolism. Answer: C. Aortic dissection. This question tests your ability to identify a high-acuity cardiovascular emergency. The key clues are sudden, sharp, tearing chest pain radiating to his back between the shoulder blades and, most importantly, blood pressure discrepancy, 180/100 mmHg in the right arm and 130/80 mmHg in the left arm. This marked difference in blood pressure between arms is a classic, highly suspicious sign of an aortic dissection, where the inner layers of the aorta tear, creating a false lumen. While myocardial infarction and pulmonary embolism can cause chest pain, they typically don't present with this specific tearing quality or a significant blood pressure difference between limbs. Pericarditis pain is often positional and relieved by leaning forward. Recognizing the classic pain description combined with pulse/pressure differentials is vital for early diagnosis and rapid transport to a facility capable of specialized surgical intervention. Question 25. You are on scene with a 55-year-old male who is having a severe allergic reaction after being stung by a bee. He is conscious but anxious, with diffuse urticaria, facial angioedema, and a rapidly developing inspiratory stridor. He has already self-administered one epinephrine autoinjector. His condition is worsening. What is your priority action? A. Administer a second dose of epinephrine via autoinjector. B. Administer high-flow oxygen via non-rebreather mask. C. Prepare for advanced airway management, example intubation or cricothyrotomy. D. Administer intravenous diphenhydramine and fluid bolus. Answer: C. Prepare for advanced airway management, example intubation or cricothyrotomy. This question presents a critical decision point in managing a severe allergic reaction with impending airway compromise. The keywords are severe allergic reaction, facial angioedema, and rapidly developing inspiratory stridor, despite having already self-administered one epinephrine autoinjector. While a second dose of epinephrine is often indicated if symptoms persist, the rapidly developing inspiratory stridor indicates immediate and severe upper airway swelling that is threatening to close off the airway. This is an emergent airway situation, and preparing for advanced airway management, such as intubation or even a surgical airway like cricothyrotomy if intubation fails, becomes the absolute priority to secure the airway before it completely collapses. Oxygen, diphenhydramine, and fluids are supportive, but securing the airway is life-saving in this specific presentation. For example, if you hear stridor worsening, the swelling is closing the air pipe, and you must act quickly to open it before it's too late.